protection. Limit repeat exposures, collimation. You can't really collimate, okay, because you're going to use the full length of the image receptor. However, the smaller the patient, yes, you should be able to collimate. We're using very high KVs, right? Which produce not only high KVs, but we're also going to be shooting through a thicker body mass. The thicker the body mass, the denser the body mass, more scatter radiation is going to be produced. All right? So you want to use some sort of shielding. You remember the difference between protective shielding and gonadal shielding? What's the difference?
The amount of lead it's in it.
Difference in thickness, yeah. The amount of material used to shield the patient. And again, one of the biggest mistakes that I've seen is I've seen techs using protective aprons to shield their patients. That's only half the amount. Minimum requirement for gonadal is 0.5 millimeters of lead equivalent versus protective shielding is 0.25 millimeters.
Or, oh yeah, 0.2.
Yeah, so gonadal is going to be twice the thickness, all right? In using your protective shielding, you put the shielding on the towards the path of the primary beam. Okay, so when you're shielding your patient for PA, it'll be like this, correct?
Mm-hmm.
What about lateral? Don't forget to cover the side. That's also a big mistake because they think, oh, well, they're shielded. Well, not really. When they go to the lateral, you want to rotate the shield. Now, some instances also is you will see some technologists not only shield the primary beam, but they're also going to shield the other side. So if you have a wraparound shield, that's even better. Because now, not only are we protecting them from the primary beam, we're also protecting them from scatter coming from the image receptor. Okay? All right. We're going to use high KV. Why do we want high KV? What kind of contrast are we trying to produce here?
Lower contrast.
Okay, we're trying to produce low contrast. That means more grays, right? Because we have a lot of different anatomical structures in our thoracic cavity. We have bone, we have muscle, there's soft tissue, there's also air. So we want long scale contrast to identify all those different anatomical structures. High MA gives us what?
Short exposure.
Shorter exposure times. Why do we want short exposure times?
Because of breathing.
You're holding the breath.
Okay.
Because you're holding your breath.
Because you're holding your breath.
Eliminate
Exactly.
So they
motion.
don't move.
So they don't move. But think about this also. Even if they hold their breath and they're not moving, is there something else that's moving in there?
Yes.
The heart. So the heart's beating. So we use a quick exposure time to eliminate
Hold
any
still,
type
hold
of
your breath, stop
motion,
your heart.
including the heartbeat. Okay? If you are going to be using a photocell, you guys already covered photocells, right?
Yeah.
Okay? 3 photocells, a left, a right, and a center. Okay? In doing a chest x-ray. All right? In doing a chest x-ray, which cells are we going to use? AP or PA? This is AP or PA. Which cells are we going to use?
Left and the right.
Okay?
The center.
You can use this. Or you can use this. Or you can use this, or use this, or you can use all 3. What I'm saying here is you want cells to cover an airy area, and you want to cover an area that has some density to it. If you're just shooting the airy area, X-rays are just going to go right through it, giving you what? A quick exposure. If you're just shooting a dense area, it's going to take longer to penetrate, so you're going to have a longer exposure. So if you do one of each, it'll average it out.
Oh, because we were told that just to do the 2 outer cells.
No, which is fine. Again, which is fine. You see what you just did? Ms. Smith said.
I just want to get it right.
I'm just saying. It's going to depend. No. You're absolutely correct. It's going to depend on your facility. That's why I said you can do this, or you can do this, or you can do this, or you can do all 3. I've seen them use all 3 cells when doing an AP or PA. Okay, but the importance here is, okay, You don't just want to focus on just one, because it's just going to take the one and just either make it shorter or longer. Okay? When you're doing both photocells on here, because it's striking two different areas, it's going to give you a slightly longer exposure than if you just did the one. Okay?
Mm-hmm.
I'm not picking on you. You know I love you, man.
Man.
All right,
I'm
here's
hurt right now.
lateral. Okay, we got the 3 cells. Okay, based on your laboratory experiment with Ms. Mitz, okay, which cell are you going to use? Do we want this one?
No.
You're not shooting anything. Do we want this one?
No.
Okay, this might give you the same effect as this, because you're not going to have a total body part in that cell. So I'm not going to do this or this. I'm just going to do the center. Okay, and again, it's gonna vary from facility to facility and whoever your technologist is that you're following around.
So some might use all 3, right? Or
We don't do all 3 in a lateral. On the
Okay.
AP and PA, you have the option of doing.
So lateral is
those
always
3.
gonna be-
Lateral is always going to be 1 cell, always, which is the center. Okay. All right. I'm going to skip this part because we are no longer doing film. Breathing instructions. Exposure is done on inspiration. We do it twice. Take a deep breath in, blow it out, take 1 more deep breath in, and hold it. Hold it, hold it, hold it, hold it, hold it, hold it. And you're watching them, right? That's why we got windows. Because I think I told you this before. You're telling them to take a deep breath in and hold it, and the moment that you turn around, they do this. Or they think that when you leave the room, it's okay to breathe. Okay? So you don't want them moving, you don't want them breathing. Keep your eye on them as you're making the exposure. Okay? Why do we, so this slide here is based on, again, we do full inspiration breaths, but there are some instances where you will do both an inspiration and an expiration breath. Okay? It is done for comparison. When would we do an inspiration and expiration? Well, we would do it for atelectasis. What's atelectasis?
Collapsed
Okay,
lung.
collapsed lung. Okay, so we're going to do a comparison with inspiration versus expiration. We're going to do it to distinguish opacity from rib and lung. Remember that calcified nipple? The doctor might say, okay, do a lateral, but I also want you to do an expiration because we want to see if that mass moves. Inspiration, expiration. If it stays in one spot during expiration, okay, that's probably the nipple. Right? If it's in the lung, you will see different locations from inspiration and expiration, okay? Fixation of the diaphragm. This is to observe any type of diaphragm mobility or motility. Is it moving or is it not moving? And then also small pneumothorax. Again, don't confuse these two. This is air in the pleural cavity. Atelectasis is a collapsed lung caused by pneumothorax, because you can have pneumothorax without having collapsed lung.
Is that a collapsed lung right there? On the right?
This over here?
No, other one.
This one over
No,
here?
well that image, but the other lung. No, other image.
This over here?
Other one.
This over here?
Yeah, but the other, the left lung.
This left one here?
Yes.
No.
Oh, okay.
No, this is just over penetration again, but I can see some lung markings in here. And it's harder to see on these x-rays here, and I don't know why they use this as an example, but there is some, you're missing some lung markings over here that may be an indication of a collapsed lung. But it's a bad x-ray. Now, possible fluids here, there is some flattening out over here. There's definitely some flattening out over here, so this is fluid in the lungs right here. The more you see, the more you will understand. Okay. Reasons why we do, in chest x-rays, we do in an upright position. Okay. The whole purpose of doing it in an upright position is we're trying to evaluate for air and fluid levels. Okay. Also, when you're sitting up, what happens to your diaphragm? If you're sitting up or standing up, what happens to your diaphragm? It goes down, which will allow you for more air intake when you're doing inspiration, okay? So the diaphragm moves down further. It is to demonstrate air and fluid levels. And then it prevents engorgements of pulmonary vessels and heart. When you're laying down, everything kind of just spreads around and everything becomes engorged because the fluids, especially in your vascular system, is not moving anywhere. Now think about this. If you are laying on your back, if you're laying down and if you had fluid levels, are you going to see the fluid levels? Because when you're laying down, everything just kind of spreads out. So now you're not going to see the fluid levels. So the best way to do this is in some kind of upright or erect position. Why do we do 72 inches? Most of the x-rays that we've done so far has been done at 40 inches, right? Why do we do it at 72?
Isn't it for magnification?
Okay. Yeah, to decrease magnification. Okay, because there is some OID. Even though your chest is up on the image receptor, your heart will not be. Okay, that's why we do it PA. Our heart is going to be closest to the image receptor. We don't do it AP because that makes it further away. But we also do it at 72 because the doctors look at the heart size. They look for the true heart size to determine whether or not there is heart pathology. So if we can get it to true size as possible, we can accomplish that by getting at 72 inches, and it puts the size of the heart in true proportions.
But like in trauma or emergency, we do AP, right?
In trauma situations where they can't get out of the bed or out of the gurney, gurney, or the wheelchair, you do them AP because they won't be able to stand up for you. So you do it with the imaging plate behind them, not on some kind of image, not on a bucky per se. Okay, so this is why we do 72, and then we looked at the lateral. Okay, are we doing right or left?
Left.
Left lateral, because again it puts the heart closest to the image receptor, and we do 72 to decrease magnification, putting the heart into true size and form. Okay? All right, we're done. We'll continue next week.
Sweet.